My name is Dominic Curry. I'm the clinical pharmacist for the burn team. I'm going to talk to you today about acute resuscitation following the initial admit of the patient, and also PO ketamine for burn changes, and also IV ketamine infusion for pain management on step down. So if you look at the board here, you can see the flow chart for the path of the patient for acute resuscitation. They come in as a trauma alert. If their TBSA is greater than 20%, we're going to calculate their fluid needs because these are the patients who are going to have the highest requirements for fluid resuscitation. So now we are currently using the consensus formula. So down in the trauma bay when they come in, we'll assess their estimated burn surface area, and we'll use this consensus formula to estimate the amount of fluid they're going to need in the first 24 hours. So it's 2 mLs times their percent TBSA times their weight. So once you get that total calculation for the total fluid they're going to need for 24 hours, you take into account the amount of fluid they've already gotten from EMS and ED as it is already, and subtract that from your total. And once you have your total, again, you're going to take half of that volume and give it in the first 8 hours, and the other half is going to be given over the next 16 hours to give you your 24-hour total. So once you have your calculation set, you're going to insert a Foley to monitor urine output, and the urine output is going to really drive how you titrate the fluids from there. So if you're someone that's working in the ICU or on the step down, you have a patient that comes in, they probably will have gotten their initial boluses, and you'll be in the phase where you're monitoring them on an hourly basis to determine if the rate needs to be increased or decreased or kept the same. So you can see here, this is all built into the order, the titration order. If the urine output is less than 30 cc's per hour, you're going to increase the rate of the fluid by 1/3 of what it is. If it's between 30 and 50 cc's per hour, you're going to keep it the same. And if it's greater than 50 cc's per hour, then you're going to decrease it by 1/3. Now, every patient is going to be sort of different. It's going to be a little bit patient specific as far as how long their urine is being maintained at a certain output for when you make adjustments. But typically, if you see someone with consistent urine output, say for instance greater than 50 for a few hours, then you're going to start to consider decreasing the rate so that we don't over-resuscitate them. And that's really important because over-resuscitation is kind of what leads to a lot of the bad outcomes with resuscitation. Things like abdominal compartment syndrome leading to decompression and things like that. They're going to really prolong their stay and make their outcomes a lot worse. So another thing we do to help reduce the amount of total volume we give in certain patients is potentially give albumin. And this is something that's a bit confusing for a lot of people because it's not very clear in a lot of places, but really what the recommendation is that at hour 12 to 18 of resuscitation, so they've been admitted, you've been resuscitating them, you're at about hour 12 of resuscitation, you're going to extrapolate out the current fluid rate that you're on for the patient. So if say they're running at 400 cc's per hour, you multiply that by 12 more hours to get whatever your total volume would be in 24 hours if you kept it at the same rate. So once you get that calculation, if that number is greater than 6 mLs times their percent TBSA times their weight, if it's greater than that amount, that's when we start considering albumin. Because that's a sign that maybe they have really high capillary leak and a lot of the fluid is not going into the intravascular space and maybe third spacing. So we use albumin to help hold the fluid in the intravascular space so that we can maintain resuscitation and keep the fluid where it needs to be. So if we get to a point where we determine that we do want to use albumin, we have to reduce the amount of LR that we're giving so that we're not giving them a lot more fluid on top of what we're giving them already. So the way that we do that, we'll use 5% albumin. And whatever fluid rate that we have calculated for the patient, we'll take 1/3 of that and use the albumin, with the remaining 2/3 being lactated ringers. And so from that point, you just continue on again with the same sort of titration based on the urine output, and there'll be a clinical decision made by the physicians as to when we should stop the albumin and how long to continue resuscitation. Generally, you're really going to be resuscitating when the patient initially comes in, because that's when the capillary leak is the highest. So after about 48 to 72 hours, the patient starts to become more hypermetabolic. They have a lot more release of catecholamines, and we're not going to need as much fluid after that point. So this is really just the first 48 to 72 hours. Now shifting gears a little bit into some of the options we have to reduce opioids during burn dressing changes. This is important because the more opioids that we use, the more likely the patient's going to have a prolonged length of stay and beyond opioids even longer after discharge. So one of the new things we're going to start doing is specifically for step-down patients is using PO ketamine because we cannot use IV push ketamine for burn dressing changes on level 2 areas. unless we have RT there and we have all the telemetry and all the monitoring, everything that's required in the policy. And that's policy 5124. So if you're looking at PO-ketamine, it's a little different. There's no PO-ketamine formulation. And so what we do is we take the IV ketamine and we draw it up in an oral syringe and we mix it with some juice to make it a little bit more palatable for the patient. So it's going to be administered similar to the way you administer the PRN morphine, for instance, for burn dressing changes. And to make sure that you give it at the right time so that the peak concentration is occurring during the burn dressing change. And so you can see on here that the order that we're going to be looking for is ketamine oral, and it'll be sent up to you from pharmacy in an oral syringe. It's going to be a weight-based dose of 4 to 6 mg per kg. And so what you'll do is, and this says it in the order, you'll take that oral syringe and you'll mix it with 4 to 8 ounces of either juice or cola, because it's a really bitter tasting medication and it makes it a lot easier for the patient to take it. So you'll mix that with the juice or cola and you'll give it 30 minutes prior to the procedure so that the peak concentration is occurring while the most painful part of the dressing change is occurring. Some of the adverse effects that you're worried about, these are really rare for PO-ketamine. But if you're, especially when we're using the doses that we use, which is less than 6 mg per kg, you're really not going to be too worried about this. But you still want to look out for some of the things you think about with ketamine, the psychomimetic effects, so hallucinations, nightmares, delirium, hypertension, tachycardia is also possible. You can really manage if they do have any effects, psychomimetic effects. You can use PRN benzodiazepines to help with that. And really, the only other thing is just the nausea and vomiting, which again is helped out by the juice being mixed with it. The last thing I'll talk about is ketamine infusion on burn trauma step down. And so again, this is the purpose of this is to provide some opioid-sparing effects to reduce our overall opioid requirements. And so you can think of it as a sort of a basal pain control that we have running in the background as a continuous infusion to help reduce the overall number of PRN opioids that we're using on a daily basis for them. So we can use ketamine infusion on level 2 areas per the policy. And you can see here that there's 2 orderables that we have for ketamine infusion. It must be the low dose orderable for pain management that we use. And that'll basically cap the dose so that we're not getting into the anesthetic doses and we're just keeping it at pain management. And so the sub-anesthetic dosing, again, this is what we'll use on the step-down units. We'll start at 0.05 mg per kg per hour, and then we can go up to as high as 0.5 mg per kg per hour. As far as titration, we're recommending that we do not titrate because, again, it's really meant to be a basal pain control, and the thing that you're titrating essentially is the PRN opioids. And so you'll put the starting dose on, whatever is deemed to be appropriate for the patient, and you'll see if you're using more or less PRN opioids, and that'll determine if you need to go up or down on the dose. But given that the nurse-to-patient ratio is a little bit higher on level 2 areas, it'd be pretty labor-intensive to monitor every hour and document every hour and titrate every hour. We don't really feel that you're going to gain a lot because of the way that we're trying to use it. And so normally it'll be ordered as do not titrate at a specific dose. If you're seeing that it's working pretty well, you can keep it that dose. If they're requiring a lot of PRN opioids still, then we can contact the physician and have them increase the dose. Some of the adverse effects, again, it's very similar to what I talked about, the PO-ketamine. It should be pretty rare when you're using the low-dose infusion, but still want to look out for, again, the psychomimetic effects, hypertension, tachycardia, and again, if they do have hallucinations or delirium, anything like that, then we can order some PRN benzodiazepines for them. If you do come across any of these, obviously just notify the physician and we can go from there.